So I think things are wide open right now. We've got a middle-aged woman who has chronic fevers for 4 months now. And I think the powerful trifecta that pulls us early in a lot of cases is whether this is going to fall into the category of chronic inflammation from infection versus malignancy versus an autoimmune process, most likely with this time course. I think starting off with the chief concern of fevers, it really could go anywhere, but really, really pertinent positives and negatives will come from the associated symptoms to see if we can really sort of anchor on a particular part of the body or particular syndrome that stands out, as well as this woman's exposures that she's had as well. But Sausan, why don't we get a little bit more from you?
Okay, so everything goes back to May 2023 when the patient started to have abdominal pain for 1 month that was associated with fever. As for the abdominal pain, it was epigastric insight. It was gradual. She described it as discomfort and burning in sensation, no relieving factors. Sometimes it would be exacerbated with some type of food like spicy food. It was associated with bloating, feeling of fullness after eating small amount of food, and sometimes nausea and vomiting. After having multiple visits to the doctor, he decided to do an endoscopy, which showed gastritis and an H. pylori infection, and she was treated accordingly. After that, her abdominal pain subsided, but her fever persisted. Okay, as for the fever, it started at the same time. It started in the same time frame of the abdominal pain, but it did not coincide with it. It was documented 38 degrees Celsius on an average, no specific timing nor pattern. She would have daily fever spikes for 2 or 3 consecutive days, and then she would have a week free of fever, so there's no specific pattern. And if it happened at night, she would have drenching night sweats. And she also mentioned that after her treatment with the H. pylori infection, the fever subsided for a while and decreased in frequency, but it still persisted. And I'll stop here.
Wow, what a juicy aliquot. What I'll do is I will talk a little bit about the duration of the fevers, and then give the GI focus to you, Steph, to comment on and how that may help us make progress. And I want to say, interestingly, with fever, we're assuming it's a fever rather than elevated temperature. And I think we're doing the right thing here. But what I love most about these cases, and I learned this from one of Steph's teaching points a couple days ago, was that it really allows us to push our knowledge. And, it would be wrong not to quote Rabih here, but if someone presents with hemoptysis, you first start with blood per aurum because you're not sure if it's actually coming from the lines. In most instances, an elevated temperature would translate to fever, which would mean inflammation, and then you look for the source. But sometimes an elevation in temperature is not a fever, but rather hyperthermia, meaning it's not an actual rise in the temperature set point in the hypothalamus, but it's rather a problem with thermoregulation and homeostasis of the body temperature. Here, we can be rest assured that we're not dealing with that type of problem. Just given the duration, we're very concerned for some form of inflammatory process. And as Steph mentioned, that once you have fever and you say inflammation and you're thinking of that trifecta of infection, malignancy, autoimmune, it's really interesting. Like the infections that you worry about, they're not your typical infections of pneumonia, UTI, gastroenteritis, or skin and soft tissue, but rather more those unusual organisms that tend to hide in macrophages or in parts of the body that tend to have a prolonged course. So mycobacterial infections, fungal infections. And more recently, what I've added to that list is a typical organism that is walled off. And I saw that in a case of a patient with an abscess that had a prolonged fever. So I will pass the mic to Steph to talk about the more relevant part of this HPI.
Thanks, Reza. Yeah, I think the key question we're left here is this abdominal syndrome that she has with bloating and discomfort associated with the fevers and the finding of gastritis. Is it all one thing, or are we actually looking at two different processes going on? The fact that at this point in the case, we know she's had an endoscopy is very helpful because we found a potential explanation for the abdominal syndrome, this sensation of discomfort with eating, the bloating, sometimes is framed as dyspepsia, which is a very nonspecific term, but one of the many causes that can give people these dyspeptic periprandial symptoms is gastritis and potential, and specifically H. pylori gastritis. So the question is, have we sort of satisfied and closed the abdominal syndrome by finding this diagnosis and treating it, and we're left with still then unexplained fevers without a localizing organ system, or are they related? I guess, Austin, can you clarify with the H. pylori treatment, to what extent the abdominal syndrome got better?
She mentioned complete resolution, but recently she started to have discomfort again.
Okay.
But less than before.
Less than before. Okay. So the test of treatment to some extent can be helpful generally in cases when something is treated and the associated symptoms go away. Even if you're not 100% sure whether the diagnosis you treated was the primary driver, seeing if it gets better with treatment can be helpful to confirm that. But it sounds like it didn't go away completely. So I think we are still left with the framing of a middle-aged woman with chronic fevers, epigastric pain with bloating that has persisted despite treatment for H. pylori gastritis is sort of how I would think about this now. I will say, even though her symptoms haven't gone away, we've made some progress kind of checking off some of the more sinister diagnoses that fall into that trifecta of inflammation from infection, malignancy, and autoimmune. We know she doesn't have an upper GI mass at this point. I think that's very important to know, whether primary gastric cancer or lymphoma. We know there's no obstruction there right now. So I think while we still have a wide open syndrome of now a chronic epigastric syndrome with fevers that didn't go away with PPI and short-term antibiotic treatment, we've actually, had some major upper GI pathology crossed off the list with the EGD itself. But there's still a lot of systemic syndromes that can cause nonspecific abdominal pain and discomfort. So part of me is wondering at this point, do we need to start thinking about the rest of the GI tract, including the hepatobiliary system, to localize on those symptoms? Or are we going to start getting a flavor of more of a systemic process that is non-specifically involving the upper GI tract? But interested to hear more to see what direction we go in.
Okay, so during her fever episodes, she would also have joint pain involving both her upper and lower limbs and generalized fatigue. She also mentioned that during the past 3 months, she has lost around 14 kgs. And she also mentioned having a rash with a malar distribution that is sun sensitive, but no other like body rash or skin ulcers. And she has mouth ulcers infrequently that are painless, let's say. And her review of system was positive for dyspnea. And for her past medical history, she's a known case of type 2 diabetes, which she takes metformin, and her other daily medication that she takes is famotidine. She denied any use of weight loss supplements or any other vitamins. Her family history was significant, as two of her siblings were diagnosed with Crohn's disease in their early 20s. Her sister has type 1 diabetes. Her mother was diagnosed with FMF in her adulthood, but the patient does not recall the age of her mother's diagnosis. And also, she has a family history of hypertension, diabetes, and coronary artery disease. As for the social history, there is no recent travel history, animal contact, or zoo visit, sick contact, unpasteurized milk ingestion, or dentist visit. She's a non-smoker. And for her past surgical history, other than her endoscopy, she did a colonoscopy, which was free.
Great. Wow. A ton more information to work with here with Sausan. Reza, let me just share some thoughts about the additional symptoms she had, and then I'll leave to you layering on her past medical as well as potentially very important family history factoring into what's going on. So with the addition of the fever-associated joint pain, which at this time I think we can call arthralgias, we'll see on exam if there's actually arthritis with synovitis accompanying it, the weight loss, and then mucocutaneous symptoms, I think we really do need to shift our focus into potential systemic as opposed to upper GI or hepatobiliary primary causes of this chronic febrile syndrome. I think expanding within the specific subcategories we've mentioned already, certainly this syndrome of having joint symptoms along with mouth ulcers and a photosensitive rash will make us extremely important to have early upfront an ANA, both to look for lupus as well as other connective tissue diseases that can have that imprint on the skin, the mucosa, and the joints as well. And then some of the kind of chronic infections also, I think will be very important to think about what exposure she had, which we'll dig into shortly with Reza, and what could actually cause rash as part of it, which is really a lot of some of those chronic intracellular organisms that we mentioned early before. I think I'll stop there, Reza, and see what you want to layer on with the additional story.
Steph, I never want you to stop. Like, listening to you is so soothing for the mind and the soul. I love the way that you frame this case and how you really use reflexive thinking to say, I want an ANA now. And I learned this on Twitter because I had posed the question, like, why does the malar rash of lupus spare the nasolabial fold? Right now, you can see I'm out in the sun. The nasolabial fold is protected from the sun, and it's a photosensitive rash. So that's why you have sparing here, unlike a primary cutaneous process that's independent of the sun exposure. And interestingly, like, listening to this case prior to the rash and the ulcers, it's just so non-specific stuff. Like, it's like really hard to prioritize a specific diagnosis. But now that we're getting this additional information of the inflammatory bowel disease with the FMF, I'm finding myself, how rude is it that that helicopter is flying over us right now? As if he doesn't know that we're discussing this important case. But I'm really finding myself prioritizing an autoimmune disorder like IBD lupus or an autoinflammatory disorder, which FMF is a prototypical example of. If you ask the question, what distinguishes autoimmune versus autoinflammatory? Autoimmune is in response to an antigen, while autoinflammatory is antigen independent. I know with IBD like Crohn's, there tends to be, like, having a family history and a first degree relative actually increases your risk factor of having IBD. And when I think of IBD and I try to link it to the joints, I'm in that seronegative spondyloarthropathy category. And then when I incorporate the ulcers with that family history, all of a sudden I'm thinking of IBD, Behçet's, lupus, but then I pause. And something that Sausan said that we don't often get on history is the quality of the ulcer. Here she said it's painless. We've all had aphthous, well, not all, I've had aphthous ulcers before. They're painful, they're not painless. I've also, in taking care of patients with HSV or CMV, those ulcers are quite painful, and the inflammation that happens in the oral cavity. So the painless nature might also be consistent with lupus, I believe. So I wouldn't put too much emphasis on that. Could this be just an aphthous ulcer that's very common and unrelated to what's happening? Potentially. But I love how you just incorporated that into arthralgias, mucosal ulcer, cutaneous finding of the malar rash. As far as the FMF, I don't have a robust illness script for it, and I'm not ashamed. I don't see it often. What I do know about FMF, it's an autoinflammatory disorder, tends to be at higher rates in the Middle East, and patients tend to present with exacerbations of abdominal pain and fever. And they tend to be colchicine responsive. I think that's in thinking of like treatment being a diagnostic step. I know I just talked a lot of stuff. I would love for you to reflect on that. If there's any additional thoughts, I saw you taking some notes that you would like to layer on. I'd be appreciative.
Really love just the differentiation between the autoimmune versus autoinflammatory. I think a distinction that was just put so nicely that makes it very clear kind of where the stimulus is coming from versus not for the immune system revving up. I think my only other thought I want to add is, Sasan, just a beautifully pertinent set of negative exposures that you gave us. For example, you mentioned lack of exposure to unpasteurized dairy products. The illness group for brucellosis is high fevers, drenching sweats, arthralgias. I believe there can be skin manifestations also. So just want to give you a shout out for really giving us important information, including that wasn't there when it comes to just some of the other environmental exposures. For me also, her family history really just hangs heavy right now in the balance with this these two syndromes of FMF and Crohn's there also. And so I think looking forward, really, I think we'll still need to be very cautious to get the history and exonerate infectious pathogens, because if we are in any autoimmune or autoinflammatory category, she might eventually need immunosuppression as part of her treatment. So thinking a little bit ahead towards management reasoning, what this woman may eventually need is really going to require a robust evaluation, particularly for infectious etiologies, if we ultimately end up in the kind of autoimmune, autoinflammatory spectrum of disease. But shout out, Sasan, for just giving us really, really great additional details that help us prioritize different things we've listed on the differential.
Okay, so moving to the physical examination, her vitals at the time of encounter, her temperature was 36.3, her pulse was 109, her respiratory rate was 20, and blood pressure was 138/76. She had conjunctival pallor on examination. As for her cardiovascular examination, regular rate and rhythm, no murmurs were heard. As for her pulmonary examination, no distress, normal breath sounds. And for her abdominal examination, there was mild hepatosplenomegaly. Otherwise, nothing was remarkable. So initially, this patient was seen in the clinic due to her persistent intermittent fever. So the doctor ordered some tests for her. And when the results came out, there were some like abnormalities or something, and they were not very good looking. So so this prompted her hospital admission.
And Sasan, before you give us those, I think there's like a really important point here. Sorry to interrupt, by the way, your presentation. And that, I just want to sort of dance with Steph very momentarily, because I think it's a great teaching moment for our audience members. Steph, like I'm just curious to your thoughts. Like if you were to see this patient in clinic, the pallor, like how are you, I guess, putting it together? Like even like, I guess, trying to predict what we might see in these labs and the data that comes by.
Yeah, I think important, because in real life, right, when you see her in clinic, you hear the syndrome where she's been sick, you have to decide what labs to order, right? And so anticipating what the abnormalities are is important, because that'll decide what check boxes you're going to go for. I'll comment that in the labs, I think we are going to expect to see signs of chronic inflammation. She doesn't have a fever right now in front of us, but she's tachycardic without a fever, which I do find worrisome for something, right, just driving her inflammation forward. So will we see either leukocytosis or perhaps more morbidly leukopenia in her labs? Will we see chronic thrombocytosis? And with the pallor that we're seeing, anemia being present, we'll have to sort of sort out later if it is there. Is that reactive to the inflammation, or is actually blood loss or destruction part of what seems to be evolving into a systemic process for her? And with the hepatosplenomegaly, the abdominal discomfort she's had, many of the diagnoses we've mentioned non-specifically can cause hepatocellular injury. So I won't be surprised if we see hepatocellular inflammation in an ALT or AST elevated at this point. So, you know, one might say off the bat, you're going to get a CBC and a complete metabolic panel in this patient, but I do think kind of anticipating when you meet with her, what you're going to get is critical. And I will put a plug again in hearing this chronic inflammatory syndrome, in addition to the ANA and early tests that would completely change our diagnostic journey for her, will be a HIV screening also. So in clinic, right, thinking about the labs and particularly those two ones, the ANA and the HIV, will just be huge branch points for us going forward.
Thank you so much, Steph. Sorry for interrupting, Sausan. Back to you.
No, it's okay. So her white blood cells were 5.6 with a neutrophil predominance, 89.9%. And she had low lymphocyte count with 7.5%. Would you like to know the total count of each differential?
Please.
Her neutrophils were 5,300 and lymphocytes were 1,000. Her hemoglobin was 10.4, but at the time of encounter, it was around 7, so she had a 1 unit of blood transfusion or of packed RBCs. Her hematocrit is 30.4, MCV 71.9, MCH was 24.5, and RDW was 19.6. Normal platelet count, it was 315K. Blood film showed hypochromic microcytic anemia with hypersegmented neutrophils and no rouleau formation. Should I stop here or should I complete with the chemistry panel?
Why don't you give us the chemistry also?
Okay, so her sodium was 131, potassium was 4.23, chloride was 94, urea serum was 51, creatinine was 5.35, with a ratio of 10. She had normal liver enzymes. Her alkaline phosphatase was 75, total protein was 6.7, her albumin was 3.22, calcium serum was 11.5, her magnesium was 3.29, she had normal creatinine kinase, her uric acid was 8.02. She did a urine analysis, which showed few white blood cells and RBCs. Hemoglobin and protein were positive, no urine microscopy, and her culture was negative. And her urine creatinine was 0.02. Albumin random urine was 11.6. Would you like me to stop here or should I complete?
I think we've got a lot. Reza, do you want to kind of hop in first, chatting about just any of the general lab trends in the CBC and the CMP that stand out to you? And maybe then I'll just add a comment about the UA and just say kudos, Sausan, that this, and when I mentioned the HIV and the ANA up front, a important consideration early is a UA for systemic conditions. So thanks for providing that.
Absolutely, Steph. And Sausan, just to clarify, the creatinine, what's the normal value for your lab? Is this creatinine of 5 elevated, or is that based on the units?
They were considered elevated. She was admitted due to acute kidney injury. They
Okay, so normal is 1 or less for you. Is that correct?
I have to check because
oh, that's okay. Yeah. No worries. As you're checking, I'll start talking. Yeah, I just want to make sure we know exactly what the issues are. And I think, starting with the CBC staff, I like you predicted, the conjunctival pallor has a high positive likelihood ratio for anemia. And whenever you have anemia, the question becomes, are you dealing with acute anemia or not? Actually, I think that's the first branch point before you even look at the MCV. And I think the MCV here would be helpful if we had it. The reason I think that's the first branch point is because there's only a few causes in medicine of acute anemia. And one could say if the tachycardia is from the anemia, then that further supports the hypothesis that it's acute in nature. And it prompts consideration of blood loss, hemolysis, or like an acute myeloid leukemia. And in this case, you really have to think about hemolysis as soon as you start saying hepatosplenomegaly. So that would take my attention to both the MCV, because if the MCV is a bit elevated, that could be a marker of the reticulocytes, and that could also explain the high red cell distribution width, where you have different size red cells. But I would also look at the AST, I would look at the LDH, and I would look at the bilirubin, and I would get a Coombs test. Because when you start talking about this autoimmune, autoinflammatory hepatosplenomegaly, it's hard not to think of a hemolytic process. And so I'd be looking for that data. The white blood cell count is really interesting. Just like you, Steph, I was predicting either a leukopenia or a leukocytosis, but it's sometimes a little difficult to tell in someone who has renal injury. And if they're not excreting adequate volume, you don't know how much of this stuff could be dilutional from the inability to excrete the free water. But I think here the differential is more interesting than the absolute count. That being said, it doesn't make me think of just 2 or 3 processes, because really any inflammatory process can lead to lymphopenia. But I would be very interested in the HIV, as you had mentioned, as like one particular virus that we associate with lymphopenia. And here we do have the MCV at 71. So I would still get a retic count. I would get a smear. I would look at that LDH. And the AST, it seems like we may have the AST down here too. So going on to the chemistry, before I pass the mic to you to comment on the UA and add any additional thoughts, I think the when you're like scanning information, trying to decide where to invest your cognitive energy, the severity of particular abnormalities will draw your attention. Generally, when I see an AKI in a hospitalized setting, I don't put too much emphasis on it because it's mild and it's the kidney's often a bystander of what's happening elsewhere. But in this case, once the creatinine is that elevated, coupled with the UA, which you'll discuss, you do have to start thinking, well, wait a minute, can I have such a kidney injury? And Tony Bruce showed this in a tutorial that AKI can lead to low EPOGEN. Low EPOGEN can also contribute to the anemia. But I would just use the framework that we were taught in medical school of pre-renal, renal, and post-renal. And already I'm seeing something else that's very interesting here. And by the way, I'll let you, Steph, take that a bit further as to, I think there's evidence on the UA that maybe we're dealing with intrarenal, and intrarenal can be broken down even more. But something interesting I saw here, and I just had to verify this with Sasan. Sasan, is the normal calcium for your lab, is this an elevated calcium? 11.5?
It's considered
okay. All right, this is really helpful because, you know, sometimes normal or mildly elevated is extremely abnormal. And what do I mean by that? We have an elevated creatinine. We're assuming AKI. We don't have the baseline creatinine, but it's good to have that assumption of AKI. But what does the kidney do in calcium homeostasis? The kidney is responsible for 1 alpha hydroxylation of 25 vitamin D, and that active calcitriol or 125 vitamin D reabsorbs calcium from the intestine. So often patients who have impaired kidney function, especially chronic kidney disease, become hypocalcemic, hyperphosphatemic. They become hypocalcemic because of the kidney's inability to hydroxylate that 25 vitamin D. So when I see a calcium that is this elevated in the context of AKI, I wonder if we should incorporate hypercalcemia into our frame as well. Maybe it's noise. It's just unusual to see it elevated to this extent with concomitant kidney disease. And the final thing I'll say is if you don't know what the prior creatinine is, always assume it's acute. But there's a few things you can use to help you distinguish between acute and chronic, and that includes a PTH. So if the PTH is very elevated, supportive of chronic, but even better than the PTH is analyzing the size of the kidney. So if you have small kidneys on imaging, that's highly suggestive of a chronic process. And Steph made that exact point a few days ago when we got imaging and there was like a normal sized kidney. And she was saying, oh, this speaks to the subacuity or acuteness of the process. But Mike, to you to layer on, reflect, and talk about that UA.
Yeah, I think that discussion, Reza, of the calcium is unexpected and it's high. It's hard to know how much to blame it for. And I'll just make a brief comment on that before transitioning the UA and why I think the UA deserves its own special discussion. But one could frame kind of wondering, has chronic hypercalcemia been part of this? We hear about the moans and stones and groans. You know, has her joint pain, her abdominal pain actually been a chronically elevated calcium? Maybe. But I'll also say, while this is high, it is not super high. So I'm also not totally ready to, for example, blame that as the primary driver of the pretty severe kidney injury also. So Austin, if you don't mind, will you just repeat one more time the kind of parameters in terms of number of whites, reds, and protein quantity on the UA?
Yeah, sure. As for the UA, the white blood cells were 5 to 7 per house power field. Urine hemoglobin was +2. Urine RBCs were 0 to 5 per house power field, and urine protein was +1. Is that what you were asking for?
Yes. So white blood cells were 7 or less, and the red blood cells were, you said, less than 5. But 2+ heme and 1+ protein. Okay. Why did I separate the urinalysis at all from so many labs? We could talk so much about it. You know, Reza, we didn't even touch on the uric acid, but we'll sort of leave it for there and see how that ties in later. I'm again like trying to find what string to pull in this case, right? Because we've got this multisystemic inflammation, right? Skin, mucous membranes, joints, liver, spleen, cytopenias, lympho, and it's everything. But the creatinine is really, really high. And so to me, the UA is valuable in a case like this, because as Reza hinted at, I think we're really going to worry about intrinsic renal injury in her. Middle-aged woman, doesn't have risk factors for obstruction, you know, probably early in her course is going to get volume resuscitated, at least for the hypercalcemia. But assuming the kidney injury doesn't go away with that, we're left with the intrinsic category. But as we've discussed in prior sessions before, we really have to break that down anatomically even more with small vessel vascular, glomerular, tubular, and interstitial processes at play. And what do we look for in those? Tubular, sometimes we'll get lucky on microscopy, which I know we don't actually have, Sasa, and you can see the muddy brown cast, the granular cast, poof, then you can kind of make the diagnosis there and move on. Vascular often has pretty bland sediment, but then in the case of glomerular versus interstitial, and glomerular, we're used to seeing heavy protein and or red blood cells, and interstitial nephritis often comes with pretty significant pyuria, elevated white blood cells in the absence of an infection. And Saucin, you told us there's no net positive urine culture here. So I basically want to take a moment and say, like, what kind of kidney injury is of this? If we assume we're in the intrinsic category, you know, I am worried with the proteinuria that there could be some glomerular involvement there. But there's not a huge amount of pyuria, although it's not technically normal. And I will say what's standing out to me is a striking difference between the presence of heme pigment versus number of RBCs, which, tying on, Reza, to your points about this pretty dramatic anemia and what is actually driving that, does make me want to pause and wonder about a potential pigment nephropathy there as the primary driver of her intrinsic renal injury. So what do we do at this point? I am worried about glomerular pathology, and I think we'll need to quantify the protein a little more. I'm worried about where that pigment is coming from, and I think the RBCs are potentially on the hook given this anemia with a high RDW. But I'll be honest, you know, the not super high, but number of white blood cells is there also. So I'm still actually, I'm a bit torn whether to commit to calling this an interstitial nephritis versus a glomerular process. But the reason it matters is because I think certain conditions that we've mentioned on the differential diagnosis can go with each of those categories a bit more. Things like sarcoidosis, granulomatous inflammation of that, tuberculosis, often causes an interstitial nephritis, where if some of the conditions that cause glomerular pathology are lupus, right? And its other autoimmune cousins also. So the UA, I think, just takes some, dedication on its own. And I'm not looking at the chat, but I'll be honest, I'm actually like torn whether to call us in the potential interstitial nephritis versus glomerular process. I think it's important, but we'll maybe need a little more data in that, because I'm wondering with the kidneys, if some of our additional serologies that we've mentioned briefly already don't give us an answer, if that's potentially where we're going to find the signature of this underlying disease.
The one thing I'm thinking, Steph, first of all, that was incredible, is I'm also not looking at the chat, which is blowing up. There's like more than 99. I see 99 plus, but I'm just thinking how jealous Ravi and Zalvin are that you and I are actually dancing together on this case.
By the way,
they stay jealous.
I saw Zavanama before. Nobody says on. It's to not to add more jealousy. It's our wedding anniversary today. But what better what better experience than to kind of get to all be together and observing and learning together. So I'll leave it at that.
In your face, Zalvin.
Are you there? Is he still there? Awesome. Saucin, yeah, give us some more.
Okay, so her ANA was negative, her LDH was 149, ESR was 100, her CRP was 33.5, PT was 12.5, INR 0.95, her B12 was 132, which is considered low. It was documented that she had low serum iron, but no numerical value was written. Complement levels and ANCA levels were not ordered, unfortunately. So we were very unsure of what was going on. She only felt fatigued and discomfort at the moment. So the next tests that were ordered were the serum protein electrophoresis, which showed increased alpha-1 and 2 globulin and gamma globulin. Her blood cultures were negative. Brucella, cytomegalovirus, toxoplasmosis, serology were all negative. Chest X-ray was normal. Her acid-fast basalized sputum analysis was negative. She did a brain MRI, which is normal. Her echo showed normal left ventricular systolic function with an ejection fraction of 60% with trace of aortic regurgitation with minimal pericardial effusion anteriorly and posteriorly. She also did an endoscopy during her recent hospital admission, which showed severe pangastropathy with bilious liquid present and thickened folds. She also did a pan-CT, which also showed the mild hepatosplenomegaly. Her kidneys both showed increase in hyperechogenicity and minimal hydronephrosis. Her left kidney showed an ill-defined hypodensity in the lower pole and mild surrounding fat stranding. Small calcific focus is seen near the cortex. Her left there was a left adrenal gland lesion noted, which needs further investigation. And it was noted that she had para-aortic lymphadenopathy of more than 1 centimeter, and she had multiple bowel wall thickening. And as for her chest, nothing was documented. So I'll stop here and I'll see what are you guys thinking of.
Oh, Steph, I think you're muted.
Sorry, I was just saying, what are we thinking at this point? I don't even know. Let me maybe just give some quick thoughts on the additional labs that we got. And then Saucin, I want to make sure we have the complete list out there. We've got the echo, the endoscopy, and then the CT as our major kind of imaging things. Maybe Reza, I'll stall a little bit with the labs, but give you a chance to hop onto those really, I think, important imaging studies. What did we learn here with the additional labs? So I think having the negative ANA, we wanted that. Okay, I think we're out of the category here of worrying about lupus again or some of the other connective tissue conditions there. The SPEP is showing us, correct me if I'm wrong, Saucin, just pan elevation of polyclonal proteins, really just speaking to the inflammation that she's having ongoing. Pertinently, we don't see a monoclonal spike, which we maybe should have wondered about early with hypercalcemia, anemia, and kidney injury, but we don't seem to have a paraproteinemia here. The LDH not being very elevated is important too. With the elevated uric acid and the kidney injury, we had the potential specter for spontaneous tumor lysis syndrome, but the LDH should be elevated in that. The The LDH, if there's really rapid hemolysis, should also be very high for that. LDH is very nonspecific. Any cell, if it bursts open, it's released out there. So we can really worry a lot less about TLS or major hemolysis driving some of the renal injury, et cetera. And then finally, the low B12, you hinted that this would potentially be the case before with the hypersegmented neutrophils that you saw on the peripheral smear. B12 can just do a crazy number of abnormalities in pretty much most organ systems, but hematologically can cause pancytopenia, hemolytic anemia. So we know she's low in B12. The question will be why. And actually for B12, it's really complex, a lot more complex, for example, than for iron to figure out what someone is deficient. Because if you think of the whole pathway of B12 metabolism from appropriate ingestion to being attached to intrinsic factor, getting broken down by the correct environment with the pancreatic acids, needing an intact ileum to be reabsorbed, man, there's just a ton of both autoimmune, like autoimmune gastritis conditions, as well as just GI pathology. So the B12 isn't an end diagnosis, but I do think it'll tie into what her eventual problem is, which we've learned now is actually infecting her whole GI tract. With that, kind of, Reza, I'll see how you want to add on the echo, endoscopy, and CT stuff to this.
I love that, Steph. And really, I am thoroughly enjoying discussing with you, because every time you speak, and I think that's the power of being in a team, like it sort of adds to my understanding of how this case is unfolding. And yeah, and like we have so much data here. It's like, where should we focus? And sometimes it's easy because one abnormality is so severe that it takes your entire attention. And then you start explaining the other abnormalities through that main abnormality. I mean, you create a DDX, you're like, can this DX explain this? Can this explain this? Other times we gravitate towards abnormalities that we're comfortable with, and we have like a very strong schema for, and then we surround the other abnormalities around that center. And maybe as I'm talking about the imaging findings, if you could just, for all of us, just summarize, like, what problem are we solving? Like, what has made your frame that must be explained by the final diagnosis? And yeah, that the B12 deficiency is interesting. Like, while I think it's good for hemolytic anemia and schistocytes or intramedullary hemolysis, there isn't really any strong evidence of hemolysis. And I would put more weight on the LDH, the haptoglobin, the ASC, than I would on the RDW. Like, my RDW is not the thing I go to first and foremost. And then I noticed that she's on metformin, which may explain her B12 deficiency. So I'm sort of taking the B12 and maybe erroneously taking it out. We'll find out later. But here, we obviously have splenomegaly. And splenomegaly is something that we've talked about extensively on CP Solvers. So we have splenomegaly, we have bowel wall thickening, which my mind really translates to inflammation of the bowel wall. But I know that can, like, even the gastropathy, a lot of this stuff can be non-specific and not really point to a specific diagnosis. But I often feel that splenomegaly is something that I really think must be explained in this case. And then I'll see if the causes of splenomegaly that we think of could also explain, for example, colitis or enteritis, depending on where the bowel wall thickening is, small bowel or large bowel. With splenomegaly, it comes down to the mathematician's epic pearl. Is it H2O? Is it WBC? Or is it a molecule? We know it's not H2O because there's really no stigmata of portal hypertension, be it ascites on CT scan, distended abdominal wall veins, or stigmata of cirrhosis. The molecules, I mean, you can always entertain stuff like amyloidosis because that can be present secondary to inflammation, but I don't think that's where my mind is, Steph. Like, I'm really in that sort of white blood cell because the ESR is elevated, the CRP is elevated. So I'm like, what inflammatory process is causing the splenomegaly? And then we just go back to the trifecta that you said right off the bat: infection, malignancy, autoimmune. In the autoimmune category, it's really lupus, Stills, and Felty. I just reviewed our schema right now while you were talking about the other data. They're like, A&E negative lupus should not be a diagnosis that any of us makes. Like this should be only a lupus expert that makes this diagnosis. And there's no history of RA for Felties, and Stills. Usually adult onset Stills disease has a leukocytosis. This white blood cell count was normal. There's evidence of hepatocellular injury. There might be facial edema, and the rash tends to be evanescent on the chest. And you really have to rule out everything else before landing on Still's disease using the Yamaguchi criteria. So then we ask the question, if it's not autoimmune, can it be malignancy? And I feel, Steph, like lymphoma, you can never rule out. I know the LDH here is normal. The platelet count is normal. There are things that argue against lymphoma. And if we were entertaining lymphoma, it would probably be more of an aggressive type of lymphoma at this stage with like the inflammation and B symptoms. But we have some lymph nodes that are inflamed, are enlarged. We have splenomegaly. We have you can't exclude it. So I'm keeping it on the DDX. But the question is, can we arrive at a DX before, going for a lymph node or a bone marrow or some other type of, biopsy? So then we get back to that infection category. And you emphasize this, like before we land on anything else, we've got to make sure it's not infection. And here's where you and I are at a disadvantage, because we don't practice in Jordan. And we do not know, like we know in the States, what types of infections are paramount. But what we do know is the infections that do cause splenomegaly, we have to rule out HIV. HIV, we just need that test, especially in the States. Like when I was in Japan, it's not that prevalent, so they don't often think of it. But in the States, HIV, and when you think of HIV, you got to think about its two cousins, EBV and CMV. These cause the infectious mononucleosis. And so that's one bucket. I think the duration really makes a tick-borne infection that can cause unlikely. And then you're left with what you said, and I thought that was so brilliant. And we have some of this hypercalcemia, so it would be good to get a vitamin D. Can we be dealing with a granulomatous process that has involved the lymph nodes, involved the spleen, and is also invading the intestine? And for the granulomatous processes, we often think of mycobacterium, endemic mycoses, and stuff that I'm less familiar with, like leishmaniasis. I just don't have a robust illness script for that. But I would love to pass the mic to you to reflect on that and just, I am at a loss. I don't have a strong, and I feel like ultimately either it's a biopsy or some kind of unusual lab test that will give us the answer. Would love to hear how you're thinking about this.
Thank you, honestly, just for a moment to like zoom out and try and think about the framing. And I'll just encourage you guys to think about what your problem representation would include at this point. But I'm saying a middle-aged woman with a strong family history of autoinflammatory conditions with fevers, weight loss, arthralgias, painless ulcers, and then findings of lymphopenia, anemia, hepatosplenomegaly, serositis, hypercalcemia. I mean, there's actually quite a lot to fit in there. So I'll be honest, like I think it's going to be very hard to nail this down without tissue. What tissue? I am curious about kind of what's infiltrating and what's in the gastric mucosa. You know, we had a biopsy before, but I wonder again about capturing that versus a lymph node. But just to sort of explicitly kind of build on some of the particular categories you mentioned, could this be a primary kind of gastric lymphoma doing this? Maybe. So I think we definitely need a particularly of lymphoma on there because of this question of the hypercalcemia and its associations. Stills and sarcoidosis, I think, remain the most compelling in the autoimmune category. And then in addition to, I think visceral leishmaniasis is a really great thought for this part of the world, particularly with the hepatosplenomegaly. Tuberculosis, if this were a part of the world where there was histoplasmosis, I would put that on the list, but whatever endemic fungi are prevalent in the region of the world. And I'll just put Whipple's on there too. That often has a joint aches, GI symptoms picture that would be made by pathology and PCR also. So I think that's where we are, Sauce, and I want to be mindful of the time and would love to hear the final diagnostics that you guys explored and what you can teach us about the case.
Okay, so during her endoscopy, they took multiple tissue samples for biopsy, which showed mild chronic inactive gastritis, no H. pylori microorganism seen, no intestinal metaplasia, dysplasia, or malignancy in the examined specimen. And they also did a renal biopsy, which showed with the renal tissue with 8 glomeruli, 2 are completely sclerosed, the other 2 showing efferent arteries widening with hyalinized wall thickening. No glomerular hypercellularity or mesangial thickening is noted. Tubules show rare luminal calcification. Blood vessels were normal. The interstitium shows peritubular small lymphocytic and few eosinophilic infiltration, peritubular and periglomerular fibrosis. Immunofluorescence studies show IgG positive +1 linear deposit. The IgA and IgM were negative, and the complement C3 and C4 were negative and fibrinogen. And there was no evidence for malignancy. And that's it. The patient's still under investigation. We don't have a final diagnosis, but I would love to hear your thoughts about the results.
Reza, I'll let you kind of jump in first, but I'll just say how cool to have a case that doesn't have an answer, because it's man, that's real life, and this is a really hard case.
Yeah, I also want to be mindful of time. I just want to thank you, Sausan, for bringing this case and really stimulating our minds. And I just want to also thank the case review committee, and then thank you, Steph. Like, I really enjoyed co-discussing with you. Happy anniversary to you and Zalvin. And Robbie, when is our anniversary, my friend? I'm still
all day, every day.
I'll give the mic to you, Steph.
No, thank you again, Sausan. This was just really fantastic. I think this is just a beautiful case to help us explore kind of really chronic systemic inflammation, a very compelling family history, but man, despite multiple tissue biopsies, really not having a specific thought. I would love to hear follow-up on this later on from you in the future. Thanks for bringing this forward. And Mario, we'll turn it over to you to wrap us up with some teaching points.
Yes, perfect. It was a great discussion. Can you hear me well? Perfect. So we had a very interesting case with and we hope with a follow-up later to know what happened. But so at the beginning, we approached this case as an inflamed patient, and Reza taught us that high temperature is actually a syndrome, and we should be conscious that it isn't always fever. We have to differentiate it from hyperthermia, which is an hypothalamus-independent process. After that, we learned that fever is a very specific but not a perfect sensitive inflammation marker, and pertinent negatives in the history, in the history and in the physical exam and in the past medical history is very important. As we learned in this case that, for example, this patient didn't have unpasteurized milk exposure, which could prompt us to think of brucellosis. Afterwards, we were introduced, or we thought about a subacute to chronic non-localized inflammatory process, which should prompt us to think in our differential about infectious processes like atypical or exogenous pathogens, and as Reza told us, also considering walled-off infections in our patients. And here, we should always keep in mind that the HIV status is key to think or to broaden our differential diagnosis to opportunistic infections. We also have to think about systemic autoimmune, which are antigen dependent, as Reza told us, like lupus, seronegative spondyloarthropathies, IBD, Behçet's, but also antigen independent inflammatory causes, which are called autoinflammatory diseases, in which there's a very long list, but familiar Mediterranean fever is one typical cause. Then we also learned some important characteristics about lupus, that, for example, the malar rash spares a nasolabial fold just for an anatomical thing where the sun doesn't really inside the nasolabial folds, and that all our oral ulcers in lupus are usually painless. Afterwards, Reza mentioned that we can use the severity of a syndrome to as a clue on what we should invest diagnostically when we are approaching a patient. For example, he mentioned that AKI, mild AKI in a hospital patient probably isn't the most diagnostically useful data versus our community-acquired severe AKI, which we should definitely investigate upon that. Afterwards, we were learned two ways of differentiating AKI from CKD, one of which is that in CKD, we can get a secondary hyperparathyroidism from low calcium reabsorption, from low 1.5 hydroxylation in the kidney, and also from hyperphosphatemia from low clearance. And those are two causes of secondary hyperparathyroidism, which is a marker of chronic kidney disease, and also that kidney size in most of the common causes of CKD is decreased, and that can also be a marker of chronic kidney disease. And talking about AKI, we also talk about the different causes of intrarenal, which anatomically can be divided into small vessel disease, which usually gives us a bland sediment, glomerular disease, which usually gives us proteinuria, and glomerular bleeding with acanthocytes and RBC casts, and tubular, which usually can give us a very active sediment with muddy brown cast, among other things. And lastly, the interstitial compartment, which then gives us pyuria, eosinophiluria, and double blood cell, white blood cell casts. And in this, we've mentioned the UA with microscopy is very important as a key diagnostic step. Just to remind us that today was Simon and Steph's anniversary, so happy anniversary again. After that, we talked about low vitamin B12, which can be from different causes, and we have to follow the anatomic and physiological pathway from ingestion to the last metabolic steps. And afterwards, we talked about splenomegaly, that we can think about in 4 different buckets. It's either from water retention in the spleen, from portal hypertension, can be other molecules like amyloid proteins in amyloidosis. It can be red blood cells from chronic hemolysis like thalassemias, and it can be WBCs from autoimmune diseases, which particularly important are SLE, adult onset Still's disease, Felty syndrome from rheumatoid arthritis, and infections like HIV, the different viruses that cause mononucleosis, and granulomatous infections like TB, endomycosis like histo, and visceral H, and also very important bacteria like Whipple's, Trophirema Whipplei causing Whipple's disease. And lastly, to never forget about malignancies also involved in the spleen. So thank you very much.
Thanks again, Saucin. Thanks again, guys, for the opportunity today. Reza, I'll let you sign everyone out.
Thank you all.
Doo-doo. Doo-doo-doo.
Bye, guys. Have a great Friday.